Case Presentation, Eating Disorders by Florida-Bagatsing, Mental Health Nursing, Saskatchewan Polytechnic, Teacher Kara Moore, RN, BScN, MN. Eating disorders are a serious behavioral condition that negatively impacts a person's health, emotion, and a person's ability to function. It is primarily characterized by disturbances in eating habits related to distressing emotions and thoughts. Eating disorders often affects adolescents and young adults. Some forms of eating disorders, such as anorexia and bulimia nervosa, are more common in women. It can, however, affect any gender and can occur at any age. Types of eating disorders: anorexia nervosa, bulimia nervosa, binge eating disorder, PICA, avoidant restrictive food intake disorder, and rumination disorder. In this case presentation, we will primarily focus on bulimia nervosa. Bulimia nervosa is a potentially life-threatening eating disorder wherein people with bulimia secretly binge and lose control of eating and ends up consuming a large amount of food. They would then try to get rid of the extra calories and would try to purge in an unhealthy manner. People with bulimia would try to get rid of the calories they consume to prevent weight gain. They use different techniques such as, but is not limited to, self-induced vomiting, use of laxatives, diuretics, enemas, and weight loss supplements. Also includes excessive exercise, fasting, and dieting. People with bulimia are usually preoccupied with thoughts of food, weight, and body shape, which then affects their self-concept, image, and self-worth negatively. People with bulimia could be in any body shape. Some are slightly underweight, some are normal weight, some are overweight, and some are even obese. Causes of bulimia are not completely understood. It is acknowledged by the medical and psychological professionals that there is an array of factors behind the risk and development of bulimia nervosa and other eating disorders. These factors include, but is not limited to, social, genetic, psychological, and biological factors. Signs and symptoms of bulimia nervosa: preoccupied with thoughts of body shape and weight, excessive fear of gaining weight, loss of control on food intake. A person is unable to control what she eats and is unable to stop binge eating. Feeling of regret and guilt after binge episode. Repeated episodes of binge eating. This is eating unusually large amount of food in one sitting followed by purging. Compensatory behaviors such as self-induced vomiting, excessive use of laxatives, diuretics, and enemas after a binging episode. Frequent trips to the bathroom after meals for a prolonged period. Chronic sore throat, heartburn and gastroesophageal reflux, swelling of the salivary gland and cheeks, feeling of dizziness, fatigue, and loss of consciousness from excessive purging. Anatomy and physiology. Eating disorders are usually a combination and an interplay of various cultural, biological, and sociological factors. Studies and research, however, have identified specific neurobiological differences in the brain of people with eating disorders, such as anorexia and bulimia. These differences affect eating habits as well as mood, personality, and in decision-making. Neurons is an important unit of brain and nervous system. They are responsible for receiving sensory input. They communicate with each other using chemicals called neurotransmitters. The kind and amount of neurotransmitters directs the neurons. For eating disorders, two types of neurotransmitters called the serotonin and dopamine is primarily in play. Each of these neurotransmitters affects how a person thinks, behaves, and a person's personality in general, as well as the risk of developing eating disorders. Neurotransmitters. First one is serotonin. It controls memory, sleep, and appetite. Alterations in the serotonin systems were found from people diagnosed with anorexia nervosa and other eating disorders and those recovered. Researchers found that people with anorexia nervosa has a notable lower levels of serotonin metabolites in their cerebrospinal fluid as compared to people without anorexia. In addition, people who recovered from anorexia was found to have notable higher level of serotonin. They have also found correlation between higher levels of serotonin corresponding with the level of anxiety and obsessive behavior. In bulimia, researchers have found that when people go without food for a prolonged period of time, their serotonin level drops more significantly as compared to those without eating disorders. This then leads to binge eating and increased irritability. Second one is dopamine, commonly known as the pleasure chemical, as it is known to have direct link in reward motivating behavior. In addition, it also takes part in memory, hormones, pregnancy, and sensory processing. Researchers have found that in bulimia nervosa, there is a lower level of dopamine and its receptors, and binge eating is highly related to the release of dopamine in certain parts of the brain. Binge eating disorder had been related to hyperresponsiveness in rewards like food, in which eating becomes more pleasurable experience to them as compared to those without the disorder, that then leads to a compulsive behavior of binge eating. Case study: eating disorder, bulimia nervosa. Name: Miss O. Age: 18 years old. Sex: female. Address: Saskatoon, Saskatchewan. Living arrangement: lives with mother in an apartment. Admitting diagnosis: weakness and decreased level of consciousness. Presenting problem: patient was brought in by ambulance accompanied by the mother, as patient was found on the floor with loss of consciousness. Mother of the patient reported that for the past 3 months, patient had been exhibiting signs of binge eating, wherein she usually noticed that the patient's food consumption had increased significantly and is finding wrappers of food everywhere in their apartment. Apart from this, the patient had also been staying in the bathroom for a prolonged period of time post-meal. Patient history. Patient is an 18-year-old female living with the mother after parents divorced 2 years ago. Patient had a history of anxiety and depression. 3 months ago, she broke up with her boyfriend after a year-long relationship due to a cheating incident wherein the patient's friend is also involved. Patient stated that she began to eat excessively for comfort and as a way of coping due to the heartaches and betrayal of the people she trusted. Patient had put on some extra weight for about 4 kilograms in the last 3 months and became very upset about finding out that her clothes were not fitting her anymore. She searched the internet on ways to lose weight and found some laxatives available over the counter, as well as self-induced vomiting when she felt like she had eaten too much and feels regret about it. Before coming to the hospital, she reported using her fingers to stuck it down at the back of her throat to induce vomiting. She also reported that on this instance, she suddenly felt very weak, her throat feels raw, and her stomach felt very sore up until she passed out and was found by her mother on the bathroom floor. Treatment plan: social support. Currently, the patient only relies on her mother, who usually works 12 hours a day to make ends meet, following the divorce with the patient's father, who was an alcoholic. Patient had no contact with her father following the divorce. Providing the patient support through referral to community support resources is one of the priorities upon discharge to further facilitate the patient's active participation towards her treatment. Support groups. First one is the Saskatchewan Health Authority Mental Health and Addiction Services. It provides community services and counseling for children and youth below 19 years old. It includes individual and family counseling as well as dietitian services such as consults, counseling, and group educational session services that are provided with no fee. Information to contact them is in the slide. Second one is the National Eating Disorder Information Center, or NEDIC. NEDIC, according to their website, provides information, resources, referrals, and support to those affected by eating disorders. This initiative is through the use of toll-free helpline and chat. Their outreach initiative and educational program primarily focuses on the awareness and prevention of eating disorders. It is made available online and through phone and chat throughout Canada. Information is in the slide. Number 3 is the Bridgepoint Center for Eating Disorder. It is a provincial nonprofit resource center in Saskatchewan that provides program options such as recovery and healing for people who are experiencing eating disorders. They work in partnership with the Saskatchewan Health Authority. Information to contact them is in the slide. Pharmacological intervention. Number 1, antidepressants, fluoxetine or Prozac. is a type of selective serotonin reuptake inhibitor which are given to bulimia patients as it reduces the frequency of binge eating and vomiting. They are also used to treat anxiety and depression, as these are common to people with bulimia. It is usually taken once a day with or without food. It is recommended to avoid drinking alcohol and substances while taking this medication, as this may decrease the benefits and increase the side effects. Number 2, antiemetic medication. Ondansetron is an antiemetic medication developed to control vomiting on patients undergoing chemotherapy and radiation therapy. It functions by decreasing the afferent vagal neurotransmission, thereby decreasing the feeling of nausea. According to a research study about the treatment of bulimia patients with ondansetron, it appeared to normalize the sense of gratification and control of people with eating behavior. Nursing diagnosis. First one is imbalanced nutrition related to self-induced vomiting and improper laxative use. Assessment. Patient states, whenever I feel sad, I would just find myself eating a lot, and then I feel guilty for eating a lot, so I would then try to vomit in the washroom or use laxative so that I would not gain weight. Observation. Patient appears weak and tired. Intervention. Identify knowledge deficit in terms of eating disorder as well as the use of laxatives. This is to assess the patient's knowledge and understanding of eating disorders as well as nutrition and laxatives. Second is to educate the patient about eating disorders as well as the risks related to improper use of laxative as well as purging. This is to facilitate the patient's understanding and solicit the patient's cooperation in her treatment plan. Third is refer the patient to nutritionist and dietitian to establish healthy eating and elimination pattern as well as to facilitate caloric intake. Goal and outcome is the patient will verbalize an understanding of her nutritional needs. Patient will establish a healthy eating and dietary pattern and follow nutritional plan created with the help of a nutritionist. Second nursing diagnosis is disturbed body image related to fear of obesity and negative evaluation of self. Assessment. Subjective. Patient states, I am ugly and fat, that's why my boyfriend chose my friend over me. Objective. Patient appeared distressed and was teary-eyed. Intervention. Encourage patient to express frustration and anger and acknowledge it when verbalized. This is to allow the patient to unload feeling of frustration and anger and to know that these feelings is a part of herself and it is okay to have these feelings. Second is to assist patient to identify personal goal. This is to establish patient's goal and what she wanted for herself. Number 3 is to refer patient to personal development programs such as, but is not limited to, makeup and grooming to improve self-esteem and image. This is to help the patient see herself in a different perspective, to enhance the sense of self and self-esteem and image. Number 4 is to assist patient to formulate daily schedule to assist patient to have control in other facets of her life apart from dieting and weight loss. Number 5 is to monitor patient for suicidal ideation and self-harm tendencies. Anxiety and depression, panic in relation to weight gain may lead to suicidal thoughts. Goals and evaluation. Patient will establish self-worth and acknowledge self as an individual and accepts responsibility of her action. Therapeutic communication. Asking questions and soliciting information from a patient is a very challenging. Therapeutic communication. Asking questions and soliciting information from a patient is a very challenging task one must take as a nurse or any other healthcare professional. People usually give so much value in terms of their privacy and personal struggles and problems. It is especially harder for people who have psychobiological disorders such as eating disorders, as most of the time they are in denial of what they are going through. Therapeutic communication is a very important tool that could be utilized to extract pertinent information from patients as well as to facilitate rapport and in building trusting relationship between the nurse and the patient. In Miss O's case, the nurse used open-ended questions such as, "Can you tell me what happened?" to enable the patient to tell her story the way she wanted and to elaborate further to freely discuss her situation. The nurse also used acceptance and acknowledgement as well as rephrasing and seeking clarification to what the patient had verbalized. This would in turn help the patient have a clearer view and understanding of her situation. Active listening and summarizing the discussion would help both the nurse and the patient to understand the situation clearly. That would lead to evaluation of the patient's goal and in planning to help the patient achieve those goals through the help of the nurse. References: